Why is combined intratumoral immunotherapy and intratumoral ablation so important? I'm Dr. Nathan Goodyear, and of course, I am with Dr. Jason Williams of the Williams Cancer Institute. And Jason, this is a question that we hear routinely and repetitively, because when you look out in the arena of the oncological world, people are looking at ablation more and more and more as a surgical alternative.
Sure.
And immunotherapy.
Yeah.
But when I get this question repetitively, it means, okay, we've got to do a really good job of trying to help patients understand why these two are so important together. Because
Sure.
you and I played football.
Yeah.
Now, you were a kicker.
Yep.
But you understood as a kicker, by the way, he kicked in the pros.
Arena. Yeah.
That's right, arena, but they're still pros. I didn't play.
Yeah.
I didn't play. But when you lined up to kick, was it just about you?
No, it's always a team.
Yeah.
Always.
The snapper,
You got
the holder.
Every part's critical.
That's right. And if nobody blocked,
if you don't, anybody messes up and the whole thing is, then, so it's, obviously everybody looks at the kicker and thinks it's their fault potentially, but it's everybody's doing their part.
Yeah. And so for me, I played offensive line, I played center. And so there were 5 of us working as a unit. And when we didn't work as a unit, we usually got somebody really hurt bad. And then we got yelled on the sidelines.
Yeah.
But this concept of these working together really fits into that model of a team.
Yeah. Yeah, it is. I mean, so the thing is that ablation gives you tumor killing and certainly we know can give some immune stimulation. We know obviously that pulse electric field is, one of the more superior techniques for that. But then, adding on the immunotherapies at that time, makes complete sense because, you're starting that process and this is where all the immune action is going to happen, right? The immune cells are going to be there locally. So the drugs that you want to affect the immune cells, the stuff that is right there, right? That just makes the most sense, and that's where you can get the real action. That's why this works. I think it's a bad idea thinking that you're going to put the stuff from the outside. Again, it's like, why would it be coming from some distant source to get to there where it gets very, very little when you can put it right in there? And the thing is that you're already in there with a needle. It's like, so just add some drugs. It makes sense. Why wouldn't you? I don't know. It's just, it's easy. And obviously we need other doctors doing it. Unfortunately, the doctors are tied up with what insurance pays for, right? If insurance doesn't, say that they're going to pay for this, then the doctors are not going to do it. Basically they just go where the money is, right? And they do, what's paid for. And that's not the best treatments, but that's what's being done, unfortunately.
Now, you've said something several times, and I don't know if we've actually recorded this on a podcast, but you've talked about, I think it was when we were medical students, and they were, I think, doing a biopsy.
Yeah.
And you asked the either attending or resident, you asked them something that really, I think, has spurned the innovation that has brought Williams Cancer Institute where it is today.
Yeah, so it was actually in our first year of medical school because we were fortunate that they combined giving radiology with anatomy, and that was unique, and that was and which makes complete sense, right? Because radiology, you need to know anatomy, and so that's why we had an amazing training, I believe, and
LSU, by the way.
Yeah, LSU, yeah, very good, one of the best, and so and one of the things with the interventional. They had all these different, doctors talking about their parts of radiology. And then one of the lecturers, the interventional guy, comes in there and said, well, this is what we do in interventional. We're sticking needles in places and all that. I was like, well, wait a minute. Okay, this was stuff I saw in the mice. If we injected the tumors, it worked, and we knew giving it intravenous or orally didn't work. And yet everybody's telling me that was too difficult, right? You couldn't do that. And then these guys are saying, well, they're sticking needles in tumors, they're biopsying, and obviously that's how we make a diagnosis. So I thought, okay, so we can inject the drug. And I asked them that, and they're like, yeah, well, I guess we could, right? But nobody's doing it. Nobody thought about it. So,
well, I think that's just the kind of thinking that you bring to the table, because it seems like an obvious question, but yet nobody had maybe asked it or even thought to consider it.
I know it amazes me because it amazed me for so many years. I kept trying to push people, say we need to be doing this and doing it myself. But then the other doctors were like, oh no, that's crazy to inject things in the tumors. And I don't understand why. Why? I mean, the tumor is the problem. I mean, if you put the drugs in the tumor, that's going to make more sense. And so yeah, nobody was seeing that way, and now people are starting to see it. I mean, it's been a long time, and it's funny, and in a few years, everybody's going to look and say, well, it's obvious. And I think if people think about it now, and I think patients are looking, we're like, well, yeah, it makes complete sense. I mean, that's but I don't know. Still trying to convince the doctors, and the doctors, have been trained and ingrained with what they know and how to treat cancer, and so it's really hard to get them to see that there's another way. So but
it's like we're telling them that the world's actually round, it's not
that's
flat.
correct. Yeah.
So what I want to do is kind of go through a series of questions that really highlight and support the concept of why the combination of the intratumoral ablation and immunotherapy is so important. So the first one is precision. What we've had in medicine, Jason, the last 50, 75 years is kind of the one size fits all approach. It's protocol driven. But what we're doing at Williams Cancer Institute, it's really precise. It's precision. What I say, it's the right treatment for the right patient, the right combination at the right time.
That's correct.
And so I think there's no better imagery of precise than going right to the tumor.
Certainly going right to the tumor, and then when you take that tumor and you analyze it and you look, okay, what are the genetics of it? What are what's the immunological aspects of it? Because it'd be different for different patients. So whatever data we can gather from the patient, and then use drugs that are appropriate. Because for certain patients, maybe they have a KRAS mutation, or maybe we need to be using KRAS inhibitor. Right. Other patients don't have that; they don't need that. Other patients have different things. Also, there's some some of these genes, like when they look at genetic testing, you do Guardian Foundation, typical stuff like that. They're looking to see, well, do we have a drug that blocks that or inhibits that mutation? And there's a few that are available, but and then they get all this other genetic information as well. And some of those are things that give us prognostic factors, well, there could be certain genes where if they have genes that are in DNA repair, that if that and there's the typical mismatch repair that everybody talks about, but then there's other DNA repair genes. And then the other thing is, of course, you get a feel for the tumor. You look at, okay, if they have a P53 mutation, I mean, you get an understanding what this tumor is like, what it may be doing, how you could target it. So having all this data and then specifically doing for that patient, that's how we do it.
So what you're doing is, this is not protocol driven. Of course, everything has to have a plan, and then you have to pivot from that plan. But there's a foundation of science, and then you're in a way you're acting as an artist, creatively applying this for the individual tumor.
That's right. I mean, we have a base that we say, this works really well for most people. And then we look at okay, what are the other little things that we could add here and there to make it a little better? It's kind of like, us being from Louisiana, it's we have our Gumbo, and we got all the base stuff, but then you got the little extra seasoning you could add to it here and there. Everybody
got the roux,
and everybody's got their little stuff.
Little Tabasco.
They might add a little bit of this, a little bit of that, make it a little different, and make theirs different from the others. And that's kind of what we do. I mean, we when we treat this, I mean, we're using lots of drugs. I mean, it's like a gumbo. It's like a mix of lots of things. Right?
It's a gumbo.
Yeah, I mean, I think being from Louisiana, it was our nature to feel that's okay. That, I mean, you can just throw a bunch of stuff in there, and that's good. And, the more stuff you throw in, the better it is. And that's kind of what we find in these cancer treatments. The more things we throw into it, the better it works. And obviously, balance out. Look for if something's going to cause a side effect. There's some of those issues, but for the most part, we have a regimen that we know works well, that has relatively minimal side effects. The big issue is always overactivation of the immune system. That's your concern.
So, and then the next question is, what form of ablation? Because there really is a growing tech industry around ablative therapies.
Yeah.
And you've been with the ablation movement, I think, for quite some time.
Long
And so
time.
you've seen a lot of them, a lot
Yeah.
of the ones that are available to patients to this day.
Yeah.
But you've really kind of landed, and the Williams Cancer Institute, we've landed on pulse electric field therapy.
Yeah, a lot of times the doctors, and I see several other guys that do ablation, and they get their loyalty where they use a system, and then they're like married to that. I'm not that way. I mean, I just look and see what's best, and some of it's because these doctors have financial interest in like a particular company, so it makes them want to make that technology better. Whereas I've always kept out of that. I don't have a financial interest in any particular technology. I like to just use whatever's best, and whatever's best. And so, yeah, clearly, radio frequency, microwave. I mean, all that type of stuff has, been around and out there. Cryoablation, and since cryo still has its role in certain cases, but pulse electrical field, I mean, this ablative technology from an immune standpoint seems to be superior, and I can't really. It's clearly the best, and I can't even see a reason like why I could argue that any of the others you would use. Right? They're so distant.
There was a murine breast cancer model, and I found this really interesting. PEF, which is pulse electric field therapy, it's nanopulses of high voltage energy. This is a quote from this article: elicited distinct immunomodulatory effects with clear differences in serum and tumor cytokine profiles compared to radiofrequency ablation. Get this.
Yeah.
There was intratumoral downregulation of vascular endothelial growth factor, hypoxia-inducible factor 1 alpha, c-MET, interleukin 10, Ki67, tumor necrosis factor alpha. But getting into the immune function, PEF increased innate immune activation, enhanced recruitment of dendritic cells, basically M1 macrophage polarization, and reduced M2 macrophage polarization, and actually suppressed myeloid-derived suppressing cells. So the type of ablative technique was in and of itself a therapeutic against the cancer, but also a modulator of the immune system.
Yeah, it's like a bonus immunotherapy. I mean, we do it, and we're just doing it to kill a little bit of cancer. And again, that's the one big concept that messes up all the other doctors with ablation is that they want to go in and ablate the entire thing, and that will actually not stimulate the immune response. And pulse field is smaller and a little harder if you want to try to ablate the entire tumor, which is a good thing. I mean, it makes that making it harder to ablate the tumor is why it's more immune stimulating. These doctors, they try to because they'll try to ablate the whole thing. I mean, and as much as you tell them this is not the right thing to do, they just don't see it. They just have in their mind like, no, this is.
Well, it's like a surgical alternative. Cut it out. No, ablate it all.
Yeah, and so we know it's not the right thing to do. And it's interesting that the pulse electric field has such a superiority in all the things that it does that are immune stimulating. I think obviously other stuff that people might compare it to like NanoKnife, IRE. We know because my one of my partners he developed NanoKnife and he did the studies with it.
Touch on that because a lot of patients are seeing and hearing NanoKnife, which is really a brand name of IRE.
IRE, right? Irreversible electroporation. So this was technology that definitely kills cancer, and it was nice that you could kill cancer in certain areas that were delicate because it didn't mess up other structures. So there was looking at a lot for the pancreas, and it's definitely was good for that. I mean, pulse field does that and more, so it's better. So I mean, that really it's just obsolete. I mean, there's no real reason to use it, but it's still out there, so people are doing it, and but the pulse electric field is superior to that, but some people might confuse it, and so it's clearly different. The other that's come up a lot, histotripsy. Histotripsy is now getting really popular, and now I will say histotripsy has some good immune stimulating properties, so definitely an advantage to that. But I don't know if it's good as pulse field. I mean, I think it's going to be inferior, but let's just say even it's not. The difference is pulse field, we are putting a needle in there so we can inject medications. Histotripsy, they do it with the ultrasound probe, and they don't put it. There's not a needle in there.
Right.
The other thing is that because of the nature of how you need to keep the lesion very stable, you have to put your patient under general anesthesia, which is very immune suppressing.
Yep.
So you're kind of a negative trade off there. It's more dangerous, right? I mean, though you're not. It's sounds great, right? It sounds like, oh well, it's not invasive. We're not cutting open. Yeah, that's great, but it's more dangerous.
Well, I think no. It's anytime you put something down somebody's throat and you have to breathe for them. I mean, that raises the level of risk.
Yeah.
But then also you said the general anesthesia, those are all immunosuppressive.
Yeah.
And when you're trying to activate the immune system and yet you're doing it, because we've talked about Tylenol, we've talked about opiates, and yet general anesthesia will do the same thing.
It will, right? There's certain anesthesia agents. We know that. When you look at anesthesia, propofol seems to be okay. That's what we generally use.
Right. We just do sedation, right? We don't.
Right. Yeah. So we use what would be conscious sedation. The patient is asleep, but they don't need to be. They can breathe themselves. Right. So, so they don't feel anything. They don't even know. We do the procedure. They don't know anything happened. It's just as good as like any other anesthesia, but it's much safer.
Right.
And propofol seems to have some pretty good properties. I think it has even some anti-cancer properties. So it's beneficial.
That's the one that they tell you to count down to 10 from 10.
And
I remember when I got on the operating table and I was laying there and I was looking up and I saw the white bag. It's white. And they was like, oh, there it is, 10, 9. And then I woke up.
Yeah.
It was like, wow.
I've never had it.
It's weird.
Yeah. But, it's interesting. It's very lipophilic, and that's why it's a drug. Well, it's purely intravenous. Doesn't have any other forms that you can give it to patients in, as compared to like ketamine, which is another anesthetic that is anti-cancer, but you do have multiple forms of that. And so ketamine is just challenging because of some of the hallucinogenic properties that it gives some people. So, it makes it a little difficult. It has great factors because it does inhibit TGF-beta. It can be a good anesthetic. It can be good for pain. It can do those things, but the people have to be cautious just from the hallucination standpoint. They can send people in a weird way that they don't like.
Yeah, and we don't want patients tripping out on the operating room.
Yeah, we used it a few times, and every now and then we still do in patients. But like the patients, and they're in the room and they're like seeing things, and it's just problematic. So it's I don't know. This is dosing. If you get the dosing right on it, then you don't have those issues. But yeah, a lot of times the dose that is used for those, the patients have various hallucinations.
Now, you kind of touched on this just a second ago, but ablation implies, okay, if we're doing pulse electric field therapy or just cryo or any other ablative technique, it's that the sole intent there is to destroy the tumor.
Yeah.
But you mentioned, immunotherapy, activating the immune system, because I was talking through that study where it was talking about the modulating effect of the immune system. So then let me pose a question to you, Jason. Is the intent and purpose of PEF to ablate the tumor or activate the immune system?
Activate the immune system. It is essentially just another immunotherapy agent that you're injecting into it. And can you achieve an immune response without it? Yeah, you don't have to have it. It's just another agent. I can achieve immune responses with various combinations of immunotherapy. Throw one in or out there. There's lots of options. That's just another one, and and it just doesn't seem to have negative to it. So when we can, we use it. Occasionally if we're unsure, then we just go injection alone, and we can still get there. We'll still be able to do it. But yeah, it's just nice. It's a bonus. Unfortunately, it's a little more expensive. It's they charge for it like it's an immunotherapy.
Yeah, expensive.
So, the cost of the needle.
So when you hear ablation, when you hear PEF, and you see on the website of Williams Cancer Institute on our social media accounts, think immunotherapy, because that's really the intent and the purpose of it.
Yeah.
Now here was something. It was coming from a 2024 article, and they were saying that the partial tumor ablation, so not total, can trigger a stronger immune response compared to complete tumor ablation. because of the presence and preservation of tumor neoantigens.
That's correct.
And you've talked about that a lot, Jason,
Yeah.
how if we want to activate the immune system, we don't want to destroy it all.
Yeah.
We by intention want to destroy only part of it.
Yeah.
And that's a concept that's foreign to doctors,
Yeah.
and I think a lot of patients too.
Yeah, the thing is that what I observed originally, and I mean I knew this for a long time. I mean I knew it before any of these people were publishing these articles. I mean, like we were seeing it, but I couldn't really prove it. I mean, it's nice. I'm glad they publish, and our with work at Case Western we did as well. But we knew that was kind of going on. I mean, you just see it. You saw cases where, okay, you ablate part of the tumor, those patients do really well. You ablate the whole thing, patients don't do well. And yet the standard of care, if you're getting ablation, anywhere in the world, is that they try to ablate the entire tumor. And we try to tell people that's not the right thing to do. And yet, I don't know. Nobody's listening. So,
well, check out the show notes because the evidence will be there, and you can tell your doctor that they need to ablate part of it. And if they want to learn how to do that, they can always reach out to the Williams Cancer Institute.
because that's the other thing is that for the doctors, it's ablating part of it, but it's also what part of the tumor do you ablate? Because the tumor actually can be very heterogeneous, and people just look at it and say, "Well, it's a tumor and measures 5 centimeters." They don't tell you, but when you look at it, there's different stuff going on in there. And even you see the PET scan, see the other whatever scan you see, you can see that the heterogeneous of the tumor where it's got different areas, and we know that there are certain areas that we want to target. There are certain areas that are resistant. Ultrasound does a really good job of showing us this more so than CT, MRI. I mean, PET gives us a part as well, but it usually matches with the ultrasound. So these areas that are when you're scanning that are really dark, because the ultrasound obviously is a reflection of sound waves, right. And so when you have like these areas that are, we call them hypoechoic, are really dark. Those are the areas in the tumor, and you'll see it where some areas are lighter, some areas are darker. The whole tumor may look grayish or dark, but then there can be these areas that are darker.
Does that correlate with hypoxic areas?
It does. Generally, it seems to be hypoxic. Yeah, there's some that some might be fibrotic as well, but then it's like they go together, right? When you have fibrosis and hypoxia.
Yeah, because it's the hypoxic areas that are really driving the immunomodulatory effects that's favoring the cancer, the oncogenic metabolism. I mean, it's in many ways driving a lot of the show.
That's why that sort of it's been sort of determined that these hypoxic regions are almost like the command centers. I mean, they're the stuff that's controlling everything. And if you knock them out, that sometimes the whole thing just goes down with it, right? I mean, it's surprising. You would think that you have to go hit all the areas, but just knocking out the hypoxic regions of tumors sometimes is enough to trigger the whole thing to come down.
Just let it collapse. Yeah. So this is really interesting because there's actually been studies that have looked at ablation with immunotherapy and ablation without immunotherapy. And it's fascinating because the ablation without immunotherapy triggers a insufficient immune response, clearly obvious, but when you couple the two together, you get the immune response. But again, I think, and this is the next question, by the way, but it comes down to what's the purpose of the ablation?
Yeah.
Is it to try and destroy it all? A surgical alternative in a true sense of the matter. You're just not cutting it out, you're just destroying it in situ. But the really idea here is activating the immune system and let the immune system do its job.
Yeah. Yeah. I mean, the thing is that, we know that for the ultimate cures for a patient to be cured, the immune system needs to recognize and attack and destroy the cancer. So cancer, obviously is working to control the immune system, and whoever controls the immune system controls the body, and so the cancer will do stuff to try to take control of it. And so you need to have the immune system know that this cancer doesn't need to be there. It needs to attack and get rid of it. If it has any sympathy for the cancer, well, it's going to let it go, right? It'll grow, right? And that's what happens. And so that's the key, and that's why like other therapies, chemotherapies, and other stuff like that really can't be curative, because you need the immune system to know and eliminate the cancer. That is a real key. I mean, it's very hard to kill all the cancer and not have the immune system have known to get in there, because cancer will just have little pieces and lurk around and grow again. If the immune system's not on top of it, well, you didn't eliminate it.
Well, and I think that's been the fallacy of the last 100 years. It's been trying to destroy it all.
Yeah.
And in the process, it does great harm and damage to the immune system. And then that actually sets the stage for cancer to spread.
Yeah. That's why, all the therapies are just make no sense. I mean, standard therapies, or other stuff that's not, true immunotherapy. I mean, if you're not, doing stuff that's favorable for the immune system, it's detrimental. And, and a lot of the stuff, and the other parts, like obviously we know the cancer, makes the cells around it older.
Yeah.
And the immunotherapies we know actually make them younger. So we're trying to make that process. We're trying to actually make the cancer younger, not a cancer, versus chemotherapies that make things older. And the idea is that make everything old and die, but it doesn't happen, right? So,
and we've talked about that in terms of aging of cells and cell senescence, et cetera. Whereas you look at a lot of the conventional therapies out there, surgery, chemo, radiation, where if cancer is a disease of the aged cell at the micro level, and you come in with these therapies and it makes them older, that's not a double negative makes a positive. It actually accelerates the process.
Yeah, I mean, it's like you get these chemos and other stuff like that give a benefit, and there are certain situations where if you got a bulky disease, you got a patient advanced, you need to knock that down first,
right.
And then come in with the immunotherapy. That obviously is reasonable, but otherwise, just killing with the chemotherapy, I mean, it's just, you're just not going to get there.
Really interesting studies. Again, check out the show notes. It was 2012, so a little bit ago. They were looking at hepatocellular carcinoma, and they were looking at radiofrequency ablation. They were comparing it to surgery, and they found that even though radiofrequency ablation is not our favorite ablative technique, in 5 out of 9 patients, it actually induced more of a cytotoxic T lymphocyte response compared to 1 out of 9 in surgery. So surgery created essentially no immune response.
Exactly. Yeah.
And radiofrequency, a heat-based therapy.
Yeah.
And so it did create a little bit more immune response that was obviously clearly inferior to PEF.
Yeah, and there's been studies going back, gosh, I mean, 20 plus years at least, showing that the ablative technologies were superior to the surgeries, in the same situation. Which, again, like the ablative technology is so much easier, right, than surgery. I mean, that's so, but that's the direction people should be going, and obviously, it needs to be pulse field, but still, let's say maybe patients still don't have that option. Well, there's still ways you can try to get benefits. I'm not saying it's the best, but you could try to work it out with other techniques.
Right. And here's the interesting, when talking about the combination, combining intratumoral ablation with intratumoral immunotherapy is superior to ablation alone. But here's the biggest thing, and this is from a 2022 article, leading to more durable systemic immune responses.
Yeah.
Durable.
Yeah.
Sustained.
Yeah.
So with the intratumoral ablation and the intratumoral immunotherapy, people think, well, this is a treatment now.
Right.
But what we're really doing is we're creating a sustained systemic anti-cancer immune response.
Right. Yeah. I mean, I don't know. I just don't understand when patients sometimes have the situation where they're looking like, well, I could do ablation and then just ablation alone, or I could do ablation with immunotherapy. Why would they just choose ablation? That makes no sense. I mean, you could do it.
Well, it comes down to your question in medical school. Why can't we treat that?
Yeah,
you got a needle in it.
most of it again comes down to the financial aspects, because the fact is that unfortunately, ablation alone you can sometimes get covered by insurance. I mean, depending on the situation. Whereas you add immunotherapy, that's not covered, and so that's a whole different deal. And so, but again, well, patients have to decide and try to see, can they, should they. I mean, if you can do it, you need to try to inject immunotherapy in there.
So then another question is, because when people think about immunotherapy, they're thinking about the systemic delivery.
Yeah.
Which, historically, you look across all solid tumors, the response rate's poor.
Yeah.
15, 25%.
Yeah.
Now, there are some tremendous success stories that are available from the systemic approach if it's matched to the molecular profiling. But overall, it's very poor. But what about systemic immunotherapy versus intratumoral immunotherapy?
Yeah.
What's different about that? What's unique about that from the intratumoral approach versus the systemic.
Yeah, and there's several studies kind of comparing, those head to head, and you see that, again, you can use lower dose. Well, obviously, one advantage, obviously, you use lower dose in multiple combinations. That's one thing. But let's just say if you're comparing head to head, like CTLA-4 inhibitor like Yervoy, and a PD-1 like Keytruda or Opdivo, injected in the tumor versus giving it systemically. I mean, it's so much more effective in the tumor because when you give it systemically, very little of that dose actually makes it to the tumor site.
Yeah, I think we were talking the other day. You said like 4%.
4% is what we believe, and so that's just like very little. So I can take a smaller amount of drug and put it right there, and that's way more than 4%, and so it's more effective. And so the same drugs you can put in there. We've been trying to like get everybody to understand this for a long time, and the pharmaceutical companies are the resistance of this, because they don't want their drugs to be changed from intravenous, where you use more, to intratumoral, where you use less. I mean, when I first went to some of them, I won't name who, but I said, "Hey, got great news. I can take your drug and I can inject it in the tumor. It worked way better, and we're using less drug." And they're like, yeah, don't talk to us anymore.
Yeah,
like go away.
Why would you do that?
Yeah, and they're like, don't do this. Like, and then I mean, they actually then started making it hard for us. Like, I mean, they didn't want us to do some of the things.